turn it over to our, I'm going to turn it over to the rest of our team here to make specific introductions. But if everybody would please place their questions in the chat to me, I'll go ahead and ask the questions at the end of the session for our speakers. All right, take it away.
Thanks, Marcy. And thank you everybody for being present here for the third annual Margaret Coates Endowed Lecture. I'm very happy she can be with us today. We're cramming in front of one camera for a few minutes and then we're going to move to another room. I'm very privileged to just say a few words about Margie Coates. Some of you know her very well. She established addiction recovery services here at UH and directed us for 15 years. And I and others worked with her very closely for those 15 years. And I'm going to say up front, she's a mentor of mine, a good friend of mine. We work together with hundreds of patients, and she's a great, she's a good soul. She's passionate and she's compassionate, and patients responded tremendously to her care. So I'm very privileged to be able to kick this off. Margie worked for 20 years at the Cleveland Clinic. She co-directed their addiction services, and she also had a secondary appointment to the transplant center there. Her bio is enormous. Her CV weighs 6 pounds. I hope I catch a walleye this weekend that weighs as much as her CV. She's certified in psychiatry, addiction psychiatry, and more recently in the treatment of gambling disorders. She's an emeritus professor of psychiatry and anesthesiology at Case, and is a distinguished fellow of the APA, American Academy of Addiction Psychiatry, and fellow of the American Society of Addiction Medicine, Academy of Psychosomatic Medicine, and the American Academy of Osteopathic Addiction Medicine. Her clinical interests and research have focused on organ transplantation in patients with addictive disorders, addiction in women, treatment of comorbid chronic pain and addiction, and therapies for opioid addiction. She was an investigator in several multi-site trials for relapse prevention medications. She's published peer review articles on addiction and organ transplantation and on the interface of addiction and pain. She's contributed to several book chapters on the interface of chronic pain and substance use disorders. She was the chair of SAMHSA's consensus panel on managing chronic pain in adults with or in recovery from substance use disorders. Throughout her career, she served as a consultant and treating psychiatrist for the National Football League. She's contributed several book chapters on the interface of chronic pain and substance use disorders. She has presented at many national scientific meetings and has mentored numerous students, residents, and fellows in addiction psychiatry and medication. She has participated in White House and HHS summit meetings on opioid addiction, the Senate hearing for the Comprehensive Addiction and Recovery Act. I want to say one more thing about that. She came home from the White House with a beautiful, large portrait of herself and President Obama. It was striking. And I wanted to hang it in our waiting room to impress, I don't know who, patients, housekeeping, anybody. But she, of course, her humility would not let me do that. But Margie has been just a pioneer in the field of addiction psychiatry. I could go on and on, but working with her for years in what I call the trenches of addiction treatment, it's been a privilege. And since she's here, I'm going to just let her say a couple of thank yous to people online, and then I'll introduce Dr. Berry.
First of all, thank you, Bob. Dr. Ranas for making this happen. It's great to see everybody's faces again. And I have to say, being back here, I do miss you all, and I've missed all of you and my colleagues that I worked with for the past many years. Ray, thank you for those kind words.
Oh, yeah.
And Jim, it's great to see you. And hello to West Virginia.
Wonderful.
Thank you.
Thank you, Margie. It's great to have you here. Now I'm going to introduce Dr. Barry, whose CV also weighs 12 pounds, but I'm going to distill down some of his accomplishments. Dr. James Barry is professor and chair of the Development of Behavioral Medicine and Psychiatry at West Virginia University School of Medicine and the director of addictions. He is board certified in both general psychiatry and addiction psychiatry. He received his medical degree from Michigan State University College of Osteopathic Medicine, completed a general psychiatry residency at West Virginia University, and an addiction psychiatry fellowship at the University of Hawaii. I'm sure that was a tough gig. As Jim told me yesterday, he voluntarily left Hawaii to go to somewhere nicer, which is West Virginia. He loves West Virginia, and it certainly is beautiful this time of year. His colleagues at West Virginia University have developed innovative community-based treatment models in response to the addiction crisis in Appalachia, and are actively engaged in novel neuromodulation research related to substance use disorders through WVU's Rockefeller Neuroscience Institute. Dr. Barry has been a dedicated clinician and enthusiastic educator in West Virginia since the early days of the opioid epidemic. Statewide, he serves as a member of the West Virginia Governor's Advisory Council on Substance Use Disorders and the Medical Cannabis Advisory Board, which is crucial to today's lecture. Nationally, he serves on the American Board of Psychiatry and Neurology's Addiction Psychiatry Examination Committee, the American Osteopathic Academy of Addiction Medicine Board of Trustees, the Academy for Integrating Behavioral Health and Primary Care's National Integration Academy Council, and is a member of the Addiction Policy Forum Scientific Advisory Board. He has enjoyed advocating on behalf of those suffering from mental illness and addiction before audiences as varied as local town hall meetings to testifying before the United States Senate. Dr. Barry's work and opinions have led to interviews with local, state, and national media sources, such as the New York Times, Politico, NPR, the Huffington Post, and the Doctors television show. He and his patients were featured in the PBS Nova documentary, Addiction, that exposed a national audience to the science behind addiction and the humanity of those who suffer. And it's my pleasure to turn it over to Dr. James Barry. He's going to talk on this very timely subject of research, scientific-based research regarding the use of medical and recreational marijuana. And without any more from me, I'm going to turn it over to Jim. Thank you, Jim.
Yeah, thank you so much for the kind words. I'm going to try to share my screen now. Let's see. Am I sharing my screen? Can you see my presentation? Okay, good.
Yep, all set.
Fantastic. Well, thank you so much. It is such a tremendous honor to be able to take part in this today and honor one of my really dear friends and role models, Margie. My only regret is I can't be there in person to be able to do this with you all, as that would be much more enjoyable, but this is the world that we are living in right now. Let me see here. So this is a picture of Margie and our dear friend, Julie Kamek, who is another addiction psychiatrist. And we always get together whenever we can at these national meetings to plot how we can take over the world. And so, so Margie is sort of, you know, the grandmother who has laid the foundation for all of us. And really, it's hard to underestimate or overestimate the impact that she and a couple of others, really just a handful of others, have truly had in addiction medicine and addiction psychiatry. And I sincerely hope that everybody can appreciate the real work that she has done, and the fact that now addiction treatment has come to the foresight of many, and we see training programs, et cetera, et cetera. It's really been due to work that Margie and a few others, a handful of others, really have done. And she is a consummate professional and just a lovely woman. And as you can see, unlike me, she ages gracefully. So we are living in an extraordinarily fascinating time, because we have been on this journey with this incredible plant called cannabis for almost 2 decades now. And unlike alcohol, for instance, where we as a society tried to have an experiment where we prohibited what was already legal, this is sort of the reverse. We've got a substance that has been known to cause much harm and has certainly known to be addictive. Now we are releasing this into the public sphere in ways that had not been done before. And so this leaves those of us who are in the medical and clinical world in a bit of a conundrum. And so on one side, we have this push to medicalize cannabis, and a number of advocates will note that cannabis has existed and some therapeutic properties to cannabis has existed for thousands of years. And it is, in many's view, a very benign substance and can be very useful for a host of maladies. And then on the other side, you've got the recreational proportion of those who are really trying to make more and more access to this substance for recreational purposes. And so what is a clinician to do? And what I hope to do over the next few minutes that we have together, and we'll probably have to go pretty fast given the time constraints, is to at least help set the landscape and present some of the potential risks and potential harms that you probably have not heard before, and help you as a clinician figure out how you are going to come to your own understanding in this regard, and how you might be able to help patients, and how you might be able to help legislators and community members understand what this is. So a few disclosures before I begin. As already mentioned, I serve on a couple of boards related to cannabis. I have not received any financial remuneration from a multi-billion-dollar cannabis industry. And I will also note that I am indeed biased, and that my bias is this: I'm an addiction psychiatrist that's been practicing addiction psychiatry since my residency here in Appalachia in 2002. And I have had a front row to the opioid addiction epidemic from its inception in the worst place in the country. And I see so many parallels between the opioid epidemic and how that got started with industry and a number of the claims, et cetera, with cannabis and what I'm seeing now. And so the second half of my talk will be about some of these insights that I consider to be important and worth sharing. I am also biased in the sense that I want to maintain the integrity of the medical and clinical health professions. And I feel it is really, really important that those of us who are practicing, pharmacists, nurses, physicians, social workers, therapists, psychologists, you name it, that we are evidence-based, and that we are giving sound advice based on sound data and experience. This is another personal disclosure. This is a picture of me circa 1990. And looking at that picture, you could probably surmise that I am no stranger to the subjective experiences of cannabis. And so I come at this not as a prohibitionist or a believer that cannabis is the devil's weed, Rather, I come at this as somebody who really wants to share what is true about this substance and what we know about it. Trying to answer a couple of questions. What is it? What are the risks? Is it a medicine? And then what is a doc to do? Right. So medicine, cannabis, to be clear, is a plant. And this plant is not an FDA approved medication. Cannabis is a Schedule I substance, and that means that on a federal law and on a federal level, it is illegal and has no medical benefit, and that it should not be used. However, there are active ingredients in this plant, some of which are called cannabinoids. There are over 100 different kinds of cannabinoids, hundreds of different kinds of other chemicals. And it's the cannabinoids that are of most interest when it comes to potential therapeutics. That being said, there have been already and in existence 2 FDA-approved synthetic cannabinoid medications, synthetic THC, dronabinol, and nabilone, that a doctor can prescribe. And these medications have gone through the rigorous processes to evaluate safety, efficacy, et cetera. And these are available. So to be clear, in no state is a doctor allowed to write a prescription for cannabis. They can write a prescription for dronabinol or nabilone, but they cannot write a prescription for cannabis dispensed in these dispensaries. What they can do, each state has its various regulations, et cetera, but what they are allowed to do is to certify that a patient meets certain criteria and can have access to dispense cannabis. In Europe, there is another medication that is approved by their regulatory bodies of the various countries, Sativex, which is a combination of equal parts THC and CBD. And then most recently, there is a third medication that is cannabis-based called Epidiolex. And this is a medication that has been approved in the last couple of years that is used to treat very, very rare forms of some pediatric seizure disorders. I always find it interesting and ironic that the FDA approved this medication on 4/20/2018. And for those of you who know your marijuana lore, you know that the date 4/20 ranks very high as a special date, no pun intended, and you cannot avoid using different puns on a topic like this. In the cannabis culture, and then it was descheduled on 4/2020. So cannabis, again, like I mentioned earlier, cannabis and marijuana are often used interchangeably, the term, and I will do that throughout this talk. The plant itself has over 400 compounds, several of which are pharmacologically active. We know very little, or learning is more and more as time progresses about many of these chemicals, but still much is to be discovered. THC is the most notorious and the one that most users really want to be able to use. And THC is has the greatest psychoactive activity. And this is the one that is responsible for psychosis, for the addiction potential, for the rewarding potential, can also cause anxiety, irritability, this sort of thing. But THC, Delta-9 THC, is just one of over 100 other cannabinoids. Each of these cannabinoids have individual effects, interactive effects. So when they are used together, they can have some synergy. And then also what's called entourage effects. And this is a concept where whatever individual effects, they are different than when those two compounds are combined. And very, very important to note then that this plant, it can be thought of as just a big, complex chemical soup. And when you look at and when you hear reports about cannabis as a drug, you need to really think through what that means, because clinical trials that have been done with individual cannabinoids cannot be extrapolated to dispensed cannabis products that you are getting in these dispensaries. And then, of course, in the dispensaries, there is too little effective regulation to even regulate the composition of the variety among the products, the various chemicals in these products, pesticides, etc. Three main categories of cannabinoids. And the first category is endocannabinoids. And so our brain makes a natural cannabinoid, several natural cannabinoids, two of which we know of. And then there's a picture here of the brain, and you can see how ubiquitous cannabinoid receptors are within the brain. And so it always fascinates me that in our human brains and some other animal brains, there is a chemical made and receptors for that chemical that mimics plant chemicals in the environment. So you see this with opioids, you see this with tobacco, and you see this with cannabis. And so that is something that is very, very intriguing to me about why that is. And the phytocannabinoids, or the plant-derived cannabinoids, these are this is the cannabis plant, and cannabidiol and delta THC, or delta 9 THC, are the two most common ones that we know the most about. And in a shorthand term, you can think of THC like I already described it. This is the chemical that is responsible for addiction, the chemical that's responsible for psychosis, that can cause a high, and it can cause anxiety, irritability. CBD, on the other hand, seems to be more of a moderating chemical. And so this is a chemical that can possibly relieve some anxiety, possibly help with some pain. But these two you can think of in concert with one another, that CBD can mitigate some of the potential distressing effects that THC one can encounter. And then we already mentioned the other category of the synthetic cannabinoids. And so those are growing in number. Now, very, very important to get this concept and understand it. The marijuana that your grandmother and grandfather smoked at Woodstock in the 1960s is not the same marijuana that you kids are exposed to or adults are exposed to today. And so what has happened is the THC content over time has, through a very highly intelligent and concerted processes to maximize the THC potential, continues to grow. The THC content within marijuana has continued to exponentially grow over the years. And at the same time, the CBD content has been bred to remain either low or the same. And so, for instance, you could see in the late 80s, early 90s, when the early Jim Barry was a consumer at different times, the THC content was less than 5%. And then what we know of today, this has continued to increase. This is just 2011. That the THC content is average in the average cannabis plant is upwards of 17 to 28%, a big difference. And higher potency, of course, means higher risk. So and then not only that in the THC in the plant, but then also in concentrates where the THC has been distilled to high degrees of purity. And now you have products up there that are reaching 90 to even 95% now of pure THC, and is causing significant problems. This in a period of time where the FDA is recognizing that when you've got a potency of a potentially addictive and harmful substance, then it's important from a societal perspective, at least from a public health perspective, to really put some safeguards and possibly restrain that potency. And so even in tobacco now, that they are considering reducing the nicotine concentration in tobacco. No research, hear me loud and clear, there is no research that demonstrates THC content beyond 10% has any health benefits whatsoever. And the Dutch even And certainly the Dutch are not considered a prohibitionist or ultra-conservative government or state. Even the Dutch, a group of scientists and the professionals there have concluded that THC contents above 15% should be considered a hard drug. So we know this. We know that higher potency equals higher risk. And we know this even in the alcohol that we consume. So I don't know what you all drink there in Cleveland, but Yingling beer is a very popular, common beer here in West Virginia. And it's average about 4.5% alcohol by volume. And so you have a 12-ounce can of Yingling. It is much different than if you had a 12-ounce drink of 101 Wild Turkey. We know this. If you drink the can of Yingling, you're going to get a nice buzz. If you drink a 12-ounce can of 101 Wild Turkey, you will get fecal-faced pretty quickly. We also know this in the opioid world. We are dealing with an incredible crisis right now with fentanyl, and incredibly potent opioid, synthetic opioid. And you could see even a small amount compared to a heroin, you would reach a lethal dose. And you see this as the #1 driver of our dramatic increase of opioid overdoses over the last couple of years. So not only do we have this condition where the potency is increased, but we also have a double whammy that people are using much more frequently than they used to do. And so what you see here is from the early 90s into the 2000, almost 2020, you can see that the rates of daily or near daily users has increased significantly. And so it would be very common then back in the late 80s, early 90s, when I was in high school, that most people would use, and they would just use on the weekends. And so the pre-2000 average user was using 2 nights a week. Again, you have to extrapolate that that's usually weekend users. However, the average user today is a daily user. And so now you have daily use with high potency products, and you have an average increase of 70 times more THC. To put that into a perspective, that is equal to about 20 ounces, one 20-ounce Diet Coke for 35 grande cappuccinos. So what's the big deal? Here's Willie Nelson. Marijuana, it won't kill you unless a bale of it falls on you. And Willie has been a big proponent of marijuana for as long as I've known about Willie. However, kind of interesting, over the last couple of years, he's had a bit of a turnaround, and from what I understand, and some mea culpa, and has recognized some of the challenges and some of the problems, the real health consequences, both in personal health, interpersonal health, and society health that might be stepping back a little bit on that. So you have this condition now where, unlike many of these other substances that were kind of helping turn the tide on, and you see a significant decrease in psychotherapeutic drugs that have been misused over time, you see the opposite trajectory in cannabis. And so you continue to see the numbers of people consuming cannabis continue to increase. And it should be no surprise to anybody then that the more you have access to a potentially harmful substance, the more harm you are going to see. So we know that lung cancer reached epidemic proportions after cigarette smoking spread. Frequency of alcohol, liver cancers, motor vehicle accidents, abuse of relationships. All of these happened more and more so when access to alcohol became more prevalent in various communities. So past month use and past year use. So this is pretty interesting. This is a national survey, National Survey of Drug Use and Health. And this was published in 2019 or 2020, and it looked at the changes between 2015 and 2018. So here is past month use, and we'll just focus on this for a minute. So you can see that there has been an increase from 2015 to 2018 in past month use of people who reported using cannabis. A significant increase in those who are 26 and older. And so when you're looking at the national data currently, it looks like, just by looking at this particular data, that those who are using the most in greater substantial numbers are between the ages of 18 and 26 and older, so young adults. Somewhat encouraging when you look at the 12 to 17-year-olds or the high school students on the face of this data, somewhat encouraging that it's just remained constant. However, and even decreased in past year use. However, what this data did not ask is, this is just smoking cannabis or consuming marijuana. It did not ask about vaping. And this paints an entirely different story, one that should be shockingly concerning for most. And between 2018 to 2019, it had the second largest increase in this survey ever tracked for any substance in the 45-year survey history of vaping THC, incredibly common among our child and adolescent population. Only surpassed by nicotine vaping, which was the largest increase to date, and that was the year before. Drug Abuse Warning Network. So this is data that evaluates emergency departments throughout the country and attributes substance to that emergency department visit. It will probably shock most of you to know, unless you are working in an emergency department or in the addiction field, that marijuana is the second most common substance related to emergency department visits, surpassing alcohol and heroin, only being surpassed by methamphetamine, which is another huge problem we have right now. So this is another, this is the National Epidemiologic Survey of Alcohol-Related Conditions survey that's been done over the years. What I want to demonstrate here is a difference between 2002 and 2014, to make it simple. So what I'm going to do is walk you through how the respondents' use in 2002 compared to 12 years later in 2014. So those who reported using the past year, and remember, this is a survey, and so you can always assume that whatever numbers you get, you have to assume they're under-reporting. So whatever numbers, probably you would want to add to that if you want to get a more realistic sense of what the truth is. So use, just general use in the past year, doubled from 4 to 9.5%. Those who met criteria for cannabis addiction or cannabis use disorder also doubled from 1.5% to 3%. 30% of users in the past year met criteria for cannabis use disorder. And again, you all know this who are in the field, that if you have a use disorder, that means that basically your life has become unmanageable, and it's clinically significant impairment directly related to the substance, and you can't stop using it, and you're using despite harms. Young adults at the highest risk, again, this is the data that we saw earlier, which is parallel to this, that is the 18 to 29-year-olds that are at the highest risk. So use doubled from 10% to over 20% in 2014, and then cannabis use disorder 4.5% to 7.5%. Now, the Black population demonstrated the greatest increase during this time. So use went to 4.7% to 12.7%, and cannabis use disorder more than doubled from 1.8 to 4.6%. Leading George Koob, who is the director of the NIAAA, to say, based on the results of our survey, marijuana use in the United States has risen rapidly over the past decade, with about 3 in 10 people who use marijuana meeting the criteria for addiction. Given these increases, it is important that the scientific community convey information to the public about the potential harms. And so that's really what is undergirding what I'm trying to do today. So shorthand, what we do know is that for those who initiate cannabis use after they are 18, there's about a 9% of eventually meeting the DSM criteria for a use disorder. Those who initiate before 18, there is a 17% of meeting that criteria within 2 years. So it is very, very important for us to consider ways by which we might discourage those under 18, especially from using. Those who are using daily, there's about a 35 to 50% rate of addiction. This is hot off the press. This just came out a couple of months ago. What are the risks and benefits of obtaining a medical marijuana card? And this was a study that really looked over 12 weeks of those people who were on a waiting list to get into dispensed cannabis and those who were able to get dispensed cannabis and followed them. Shockingly, there was a almost 3-time increase of cannabis use disorder among those who received a medical marijuana card. And that was just within 12 weeks, mind you. No improvement in pain, no improvement in anxiety, and no improvement in depression among those who were on the waiting list. There was a small improvement in self-reported sleep. The brain, let's take a look quickly at the rat brain. So exposure to THC around birth or adolescence, the rat pups, they will demonstrate impaired learning and memory later in life. There's hippocampal changes that occur that are parallel to changes you see in Alzheimer's dementia. You probably know that the hippocampus is responsible for a number of things, not the least of which is memory. And then as we age, we have hippocampal changes, and those changes in the hippocampal cells are directly correlated with our ability to have good memory. And you see the same sort of changes occurring in those who have been exposed to cannabis. You also see an altered reward system. So cannabis pups who were, rat pups who were exposed to cannabis in the womb were more likely than to seek out other drugs of abuse when given the opportunity, or drugs of misuse when given the opportunity. Very, very interesting. Some data that's come out recently that is just staggering is that there is a cross-generational consequence to male adult rats who are exposed to THC. Before conception, their pups then, when they are born, the male offspring, they are more likely to seek out reinforcing drugs than those who are not. And this was prior to conception. Again, data that speaks to what we know about cannabis right now and the various cannabinoids and the potential harms is very, very small. And there are risks that we just simply haven't uncovered or discovered. And now we're opening up the floodgates to this substance. Gateway substance. So when I say gateway, there will be some who will get really hot on the collar and do not like that term. And why they don't like that term is because they're looking at that term in a particular way, which I am not using it. And what they would consider, and I would agree, is a misuse of gateway is, all right, you smoke marijuana, you are automatically going to be using other drugs, or you are automatically going to be addicted. And that's not what we mean by gateway. So I live in Appalachia, I live in West Virginia, and we have bears in West Virginia. So I want you to imagine that you've got a property in the mountains of West Virginia, and you've got several acres, and you've got your house, your homestead in the center of this property, and you've put a fence around your homestead. And there is a gate that allows you to enter and leave that property. So if you stay on the homestead side of your property, you are less likely to encounter a bear. If you open that gate and walk through that gate, all of a sudden you enter new territory. You enter a new territory where you are at much greater risk of encountering a bear. And that's what I'm describing when we talk about a gateway substance. It is indisputable that if you use either marijuana or alcohol or tobacco, your chances of and risk of using other substances in the future and becoming addicted to either one of those three substances or other substances is substantially higher. And that's what we mean by gateway. So this is a study, the NASDA study, again, 2004, 2014, looked at adolescents. There's self-reported use of those three gateway substances: marijuana, tobacco, and alcohol. If they used marijuana as their first drug, and they reported that in 2004, so they asked them, what was the first drug you used out of everything? So if for marijuana, if they answered marijuana, that doubled from 2004 to 2014 from about 5% to 9%. For cigarettes, they said that they first used cigarettes before anything else. Actually, the numbers dropped significantly during that period of time, for almost 20% to about 9%. Keeping in mind, however, the caveat that even though cigarettes themselves dropped, the number of people who were vaping nicotine increased significantly among the adolescent population. Alcohol, it's remained constant around 30%. So whether you were a kid in 2004 or a kid in 2014, you were much more likely to use alcohol as your first substance. Now take a minute and think why that is. Alcohol is readily available, and although it is not legal for for kids, it is legal for adults. It is very socially acceptable. And so therefore, it would not surprise you that this would happen. Should it surprise us then as cannabis becomes more and more readily available through recreational legalization and medical legalization, that the decrease in the stigma associated with that we should see also rates increase as well. Using marijuana as the first substance increased your odds of a cannabis use disorder and heavy current marijuana use, and is equal to tobacco for developing a tobacco use disorder. So you are more likely to develop a tobacco habit if you smoked marijuana first. I'm going to try to get through this more quickly. Developing brain, looking at the time we got. So more impaired effects than alcohol on cognition, both immediate and long lasting. Lower scores on verbal memory. This was a pretty notorious New Zealand longitudinal study that looked over 1,000 babies and followed them over 25 years, demonstrated a loss of 8 IQ points in mid-adulthood. Now, if you are super, super smart and you've got a lot of reserve, maybe a loss of 8 IQ points isn't that big of a deal. But if you don't, and a number of our patients don't, 8 IQ points is a big deal. All right, how about association of cannabis use in teenage years and risk of depression, anxiety, and suicidality? This came out 2019, very large meta-analysis, as you can see. Increased risk of developing depression and suicidal behavior later in life for those who were using as young people, even in the absence of a premorbid condition. There was no association, however, with anxiety. High prevalence of adolescents consuming cannabis generates a large number of young people who could develop depression and suicide attributable to cannabis. This is an important public health problem and concern which should be properly addressed by healthcare policy. Pre-adolescents and adolescents should avoid using cannabis. How about pregnancy? Surgeon General has issued an advisory warning against using during pregnancy. The CDC has reported about 16% of pregnant women use illicit drugs, and cannabis is the most common. Use of cannabis among pregnant women doubled between the years of 2009 to 2016. I'm sure our adolescent psychiatry and adolescent treatment providers are very familiar with the ABCD study, the Adolescent Brain Cognitive Development Study, one of the most important studies and highly invested studies by the federal government, currently in existence, following over 11,000 children between the ages of 9 and 11 and following these kids into adulthood. And a nice report came out last year demonstrating that those who were exposed during pregnancy, those kids after birth, later into adulthood, demonstrated greater psychopathology during middle childhood and other problems. So irritability, some psychotic features, behavioral disturbances. In Canada, so Canada is a country where now it is recreationally legal to use cannabis. This is a Canadian birth registry following over 500,000 births. There is a greater risk demonstrated of autism spectrum disorder among kids who are born to mothers who are using cannabis. Linked with increased anxiety, aggression, hyperactivity, and decreased immune response when born, linked with also low birth weight, gestational weight, and stillbirth. Important to note that THC is excreted in breast milk. Despite all of these problems, an expose looked at the cannabis that was dispensed by dispensaries, both recreational and medical. In Colorado, over 70% of dispensaries recommended. 83% of medical dispensaries recommended cannabis for pregnant ladies, and 60% of the recreational. This just came out, so I wanted to throw this in here too. Those women who use cannabis during their pregnancy, there is an association between that and children who are being born into childhood have increased adiposity and fasting glucose. So conclusion by these authors, women should be discouraged from using any cannabis product while pregnant or breastfeeding to minimize adverse effects of the offspring. Cannabinoid hyperemesis syndrome, should be something that everybody should be aware of as we see the numbers increase of users. And what this is an intense and persistent, and we're talking like 5 episodes of hour of nausea, vomiting, and dehydration. And you'll have patients that come in and they say the only thing that relieves this is taking hot showers for hours. This happens about in a third of regular cannabis smokers. And they'll come in, they'll tell you about their using a hot shower or a bath. And this is because of directly related to the cannabis that they're consuming, occurring in about 2 to 3 million in the United States annually. In Colorado, the visits for in the ED for cyclic vomiting significantly doubled after it was legalized. And the only way to really treat this is to stop smoking, stop using. Cannabis withdrawal, I will go ahead and let you all look at this in the DSM. This is a real problem. And I would say from a practical standpoint, something to be aware of, especially for those of you who are treating patients on the inpatient unit. If you notice that they're having a lot of anxiety and a lot of insomnia, whether it's in your psych unit or on the general hospital wards, really consider, is this person going through cannabis withdrawal? Heart and lungs, many of the same problems that tobacco smokers have. Again, because you are inhaling smoke, of course, you're going to have the same problems. There is a report that came out last year, I believe it was, that looked like at asthma and cannabis use disorder, there is a greater mortality among those who are hospitalized with asthma and cannabis use, higher morbidity, including intubation rates, and of course, higher resource utilization. Jury's still out regarding lung cancer because we just haven't had really the ability to look yet over time of how this can happen. This really shocked me. This came out last October. So one of the largest increase rate of cancers is HPV-related head and neck cancer, one of the fastest growing cancers in the United States. There's been a known association of cannabis use and HPV throat cancer. This is a study that actually looked at and determined the mechanism that was involved, where THC turns off that gene for cell death and therefore predicts cancer cells growing. So we now have convincing evidence that daily cannabis use can drive tumor growth. This is a cautionary tale. How about cannabis and various mental health disorders? Those of us who are psychiatrists, and especially those of us who are in the addiction field, know this just from experience. Those who are using cannabis are at much greater risk and have greater prevalence and incidence of a host of other psychiatric conditions. And surely you, like me, have had this patient experience. I have a patient who comes to me the first time and they say, Doc, I'm severely depressed. I need help with my depression. I take a thorough history. I find out that they are daily using cannabis. And so I get through the history and I start getting to my plan and work up in a sense. So I say, one of the things that I'm going to suggest you do is that in order for your depression to improve, I'm going to suggest that you quit cannabis. And let's talk about how to do that. And then what do they say? Wait, whoa. Doctor,
It's the only thing that helps me.
that's the only thing that helps my depression. And then what do I say? Why not smoke more cannabis? Why are you coming to me? If it's helping, by all means, smoke more cannabis. But why are you coming to me as a psychiatrist to help you? Okay, because my suspicion is you are still suffering from depression. And then it's time to engage our motivational interviewing organelles and really help them understand, okay, and that give and take. Let's try to do some experiments here. How could your life be better if you did it? And it's amazing. And then I try to help them understand, listen, I've been doing this for a long time and I've treated hundreds of patients. And there are so many patients that I've treated, once they've decided to come off of cannabis, they feel so much better and they are so grateful to do it, and their depression leaves. All right, real quick, association of cannabis with long-term clinical symptoms. There's been really good systematic reviews, prospective meta-analysis, worse outcomes and poor treatment in PTSD, despite the fact that in a number of states, PTSD is one of the criteria by which someone can get a cannabis card. You see greater severity of symptoms, greater severity of bipolar disorder, higher recurrence, greater major depression. I won't even get into the misinformation that has been propagated regarding opioids, prescription pain pills, and cannabis. There was a report several years ago that suggested an association between states with more lax medical marijuana laws had less rates of overdose. That was misused and misabused by the popular media at the time. Regardless, when followed over the time, actually that data reversed and there's a 20% greater likelihood of overdoses. How about risk of prescription opioid use disorder in the United States? You actually see medical marijuana more like participants more likely to use prescription drugs and more likely to misuse prescription drugs. I'm going to go real quick. Cannabis and cannabinoids for the treatment of people with chronic non-cancer pain. This is a cool study that was done a couple of years ago, looked at almost 10,000 patients in various meta-analysis, looked at non-chronic pain, cancer pain, chronic non-cancer pain. Numbers needed to treat, numbers needed to benefit was 24. And when they defined benefit was a 30% reduction in pain. And that was 29% of those who were using cannabis had a 30% reduction in pain versus 26% placebo. Okay, 3% difference for a 30% reduction in pain. When you lifted the bar a little bit to a 50% reduction, there was no significant difference from placebo. And when, on the other hand, however, the number needed to harm was 4. No benefit of physical or emotional functioning. So, medicine. There are 3 definitions that I found on the internet. A compound or preparation used for the treatment or prevention of disease, a substance such as a drug or potion used to treat something other than disease, a spell, charm, or fetish believed to have healing, protective, or other power. Okay, these were the definitions I found on the internet, and then I came up with my own definition. A label given to a substance used recreationally to decrease stigma and increase sales of the substance. And I will leave it up to you, incredibly intelligent people, to make your mind up about which definition you believe cannabis means. Now, a compound or preparation used for the treatment of prevention of disease should meet a number of rigorous standards that cannabis simply does not meet. Bringing us to opioids and cannabis. In opioids, back in the early 2000s, late 1990s, when Margie was on the front lines with just a handful of others, trying to ease the tide of people opening huge floodgates for prescription pain pills and using popular and unsubstantiated claims of benefit, minimization of harm, failure to understand addiction, chronic pain, and mental illness, and how all these 3 interact together. And then also driven by strong financial motives, big pharma, and forgetting that physicians' duty is to do first, no harm. Cannabis brings us up to today. Popular and unsubstantiated claims of benefit, minimizations of harm. I get called cannabophobic, just like I used to get called opiophobic when I would raise concerns about these harms 20 years ago. Failure to understand addiction, chronic pain, and mental illness. And unlike the big pharma of 20 years ago, now we have big pharma, FARMA, with strong financial ties and motives. And people forget that the physician's duty is first to do harm. But what we don't have in the opioid crisis, we have this whole new element of recreational advocacy. So what if Anheuser-Busch sold medical beer? What if Philip Morris sold medical tobacco? Would it cause us in the medical and healthcare field to at least pause and think, maybe, just maybe, something is amiss? Well, guess what? Big Tobacco is already in the cannabis industry, heavily investing in the cannabis industry, as is Big Alcohol. So this is Trulieve. This is one of the dispensaries. So West Virginia just became a active medical marijuana state. And this is one of the companies that is now in West Virginia. You can look this up on your own on the internet, Trulieve. So this is some of the product that they sell: Space Age Cake, Purple Wookie, Mandarin Dream. And I would ask any prescriber, any physician especially, in good conscience, would you ever recommend or condone that your patient take a product for healthcare purposes called Space Age Cake, Purple Wookie, or Mandarin Dream?
They do put those labels in the ORS reports too.
Yes, and that is fascinating to look at, which is amazing. And so here, continuing with their website, Muse. Now, everybody has a muse. For many, it's cannabis. Muse awakens creativity, giving you permission to let go. Thought experiment. Let me change the medicine that we're thinking about. Everybody has a muse. For many, it's Xanax. Muse awakens creativity, giving you permission to let go. Sweet Talk, craveable confections infused with premium quality morphine. Get a taste of delightful bites. You know you want some. And then all of these dispensaries have marketing gigs like, Vape Tuesday, 35 vape carts. Okay, just think about what are we saying to the general public and what are we getting in bed with? Now, great, now wonderful that they've got this caveat. Consult a certified physician to find out what dose works best for your condition. I would invite any certified physician to please show me what evidence by which you are basing these conclusions, please. And you have to wonder, and I know this is happening already, is that the legal implications of doing so are significant and will be significant. So it comes down to blowing smoke. If anybody knows the origin of blowing smoke, well, this was a recommended therapeutic several hundred years ago, and purported by many to solve many of the world's problems by essentially having a tobacco enema and blowing smoke. Next, what I'm trying to do is clear the smoke. More research is needed. If it is medical, then we in the healthcare profession need to be driving the discussion. It shouldn't be legislators. And actually what I say is that the current state is not medical marijuana, it's legislated marijuana, because the halls of medicine have not approved this. Every major medical society has given their grave concerns regarding this. Ours is a noble profession, and we need to protect that. First, do no harm. Medicalizing a recreational substance has unintended consequences. If you're going to do it, limit the THC to less than 10%. Add dispensed product to prescription drug monitoring database. You have that in Ohio through the ORS, and I've looked at some of the reports, and it is staggering. Don't use if you have a psychiatric disorder. Don't use if you are a child or a young adult. Don't use if you're pregnant or breastfeeding. Real quick, a number of journals in the last couple of years have come out with their review of the evidence. Paucity of, this is Pain, Journal of Pain, paucity of high quality data on cannabis efficacy and safety. British Medical Journal, small to very small improvement in pain relief. JAMA, unlikely that cannabinoids are highly effective medicines for chronic non-cancer pain. Numbers needed to benefit were high, numbers needed to harm low, with high rates of dropout for adverse events, and long-term efficacy and safety is unknown. American Journal of Psychiatry last year, there's considerable evidence that cannabinoids have a potential for harm. The current evidence base is insufficient to support the prescription of cannabinoids for the treatment of psychiatric disorders. If you are not familiar with this wonderful organization that has a treasure trove of up-to-date, great information, it's the International Academy on Science and Impact of Cannabis. Thanks to my colleagues there who have helped with this. And here is your code for the CME. I'm 1 minute.
Dr. Berry,
late.
thank you. Thank you, thank you, thank you. That was a really informative talk. I really, really appreciate it. So noting the time, for some of you, if you have to dash off to a 9 a.m. patient, please feel free to go ahead and have a wonderful weekend. For those of you who can stay a few minutes, we do have some questions in the chat for Dr. Berry.
Yes, and I'm able to stay however long.
Are you able to
folks
stay a
want
few more minutes? Okay.
Yeah,
we
I'm
won't
able to
keep
stay
you
for a
long.
while. So yep, happy to answer any questions.
Okay. First, I think a few of us wanted to acknowledge we love the photograph of you from 1990. I was even impressed with that hair. I'm not sure how you got so much long, lush hair, but that was
Yeah,
fabulous.
my wife first met me actually when I had that hair, and I think that's how I got her.
I'm sure.
And I've lost a lot of that hair over the years.
Well, it was very impressive.
It's gone to my beard.
Oh, relocated.
Yeah.
But so that was kind of an initial response. We all enjoyed that. And then our other, and a lot of comments about what a wonderful talk it was. So I just want to make sure that you hear all the positive feedback. Great
Thank you.
talk. So then some of the questions. So are there any antipsychotic benefits? It sounds like you didn't really, you're not aware of any antipsychotic benefits of CBD.
So the jury is still out on that. There's been some interesting studies that it seems to be promising. Certainly, it seems to be at least helpful in mitigating the psychotic, potential psychotic effects in some of the THC. And it is a study, it is something that is being studied, and I think it's worth following and seeing where that comes.
Okay. And Dr. Hahn had an observation that most of his patients who have medical cannabis cards buy street weed anyway, because they say that the medical cannabis is too expensive.
Yep. And that is also, one of just the realities that those who were really hoping, or at least messaging that you got to get cannabis in the hands of these people who are suffering and dying from all of this host of conditions. It's their only life-saving medication. If you could just get it, and it was going to solve our addiction crisis if you just got cannabis into the hands of the patients. Obviously, those people do not visit our emergency departments or our psychiatric wards, because it's kind of funny. Is Margie Raleigh Sullivan, and taught me that we do all of our groups. So I would, when I learned from my mentor, who's Margie's colleague, is I ran our inpatient dual diagnosis unit, and I would go through and we would do group rounds with the patients. And I would start and I would ask each patient, what substance, just every once in a while I would do this for the sake of the trainees, what substance you would start with. And invariably, each one started with marijuana. Okay, was the first substance they used, and they're coming in for alcohol addiction and heroin addiction, et cetera. And then at the end of seeing the 10, 12 patients, then I would just say, well, good thing cannabis isn't a gateway drug, isn't it? And the idea, because people have ready access. The problem is you make it even readier, and you're given societal approval, and then you're given the patina of medical benefit. And then we have the condition that I'm sure all of your child and adolescent folks see, is you see kids who are psychotic, incredibly anxious, manic, schizophrenic, and they're using marijuana. And even the parents say, I don't want them to stop marijuana because it's supposed to help their condition. And we see this over and over again. And that's the problem by medicalizing it. And then they don't take their medicine that works. We know works. They want to just keep using marijuana. Even the parents are having them do this.
Right. There's just so much confusion and misinformation about it. Okay, any statistics about the frequency of cannabis being laced with other substances?
Yeah, so that's, it's unknown. There have been a lot of sort of popular anecdotal reports that there's been these pockets of fentanyl deaths with cannabis laced with fentanyl. Those are a little sketchy. We don't really know that. And I would just be very cautious about that. But you can anticipate that in any product that is unregulated, that there's a potential for who knows what's in it. We do know that that fentanyl for sure is showing up in heroin. All the heroin we see in West Virginia is just fentanyl, but it's also in methamphetamine and cocaine, and then stamped into Xanax and other things.
Yikes.
Yeah, very scary.
Yeah. Dr. Whitney's wondering, how do we get funding for legit solid research on compounds in cannabis that might be helpful? And
Yeah.
then a lot of gratitude for the talk.
Oh, thank you so much. And that's really the key, right? And again, all right, let's really try to study it. The fact that it on a federal level, cannabis is a Schedule 1 creates a host of problems. And so it makes it very, very difficult. There's a lot of red tape and a lot of barriers to being able to study cannabis. And so the plant itself. So that means what most researchers have available is what's already been done is with the synthetic THC and some of these other substances that try to make use of that. There are movements afoot to try to deregulate from a schedule, and I would actually be one in favor of deregulating cannabis from a Schedule 1. I don't think it should be a Schedule 1 because I do think it's something that we can try to learn as much as we can from, and that just has created more problems. But hopefully there will be a loosening of some of these rules. It's kind of interesting. So in order to study the cannabis plant for medicinal purposes legally, the federal government has this harvest field in Mississippi where they use these plants with. And the cannabis, the THC content is still from pre-1980s there in that. So it's just very, very difficult right now.
And that's frustrating because it's so necessary.
Yeah.
Does the mode of THC consumption, edibles, vapes, flower, et cetera, have an association with the potential risks?
Yes. All right. So, and it's in this way. So when these dispensaries in Colorado first started opening, and one of the things they did was had no sort of information or safeguards regarding the edible products. And so you saw in Colorado for several years after these were opened, a huge increase in adolescents going to the emergency department with cannabis toxicity. And think about why that would be. So if you are a 16-year-old at a party and your buddies and are using cannabis brownies, cannabis cookies, or whatever it is that they got from this dispensary, and you're somewhat naive regarding, maybe you've smoked a couple of joints before or whatever it was, but you think, you know what, I really want to have a good time. I want to get high, and my buddies are high. And so you take a bite of a brownie. And because the brownie has to go into your gut and get dissolved and metabolize and release the THC into the bloodstream and then let it hit your brain, that takes a while, as opposed to just smoking or inhaling. So you're thinking as a, incredibly unintelligent 16-year-old like myself was, especially male, who you really don't have a lot of reserve, is that you're thinking, geez, I'm not getting high. What's wrong with this? So what do? Eat more, right? And then you start eating more. And you say, geez, I'm still not getting anything. All right, now, like an hour later, it kicks in, and now you've got buku doses in your system of THC hitting the brain, and you're psychotic. Okay, and so it's in that way that certainly the mode would affect it. But you also have to understand, it's just the potency itself. And so you have these concentrates like dab or glass where you got 85 to 90%, and they're smoking this stuff. That stuff is going directly into the brain at high doses, at high rates, and it is causing severe problems. How many of y'all had seen Reefer Madness? I figured you did. So Reefer Madness is this, you could probably find it on YouTube or something, but it's hilarious, right? And it was this huge propaganda film back in the 20s or 30s to try to dissuade poor white girls from using cannabis, right? Is really what the message was. And so you see people smoking and then jumping out of windows because they're psychotic, right? And it was, you look at it now and laugh, but what you see now is with these high THC potency products, you actually see people killing themselves, and you see people severely psychotic and doing damage to themselves and others. And so now it's no joke, where before it was like, this pretty ridiculous. Now
It
it's
should
not.
be, yeah, it should be like re-released, repackaged and re-released.
Yeah, let's do that. Let's put
Yeah.
together, let's film a video.
Yeah. And then requests for either like a handout, or if you are able to share any portion of your talk with us.
I'll share the whole presentation.
That
Just
would be
let me know who
amazing.
to send it to, and
That would be
you're
great.
welcome to have it.
That would be great. And then
And my email is on that first slide too, so people can always direct.
oh, good,
ask me
good. And you can also ask me and I can direct you to Dr. Berry. And then we'll do one last question. So Andrea writes that she works at the Gathering Place, a community cancer center, where they provide support to persons with cancer and caregivers. At times, referral to a psychiatrist is indicated. So, oh, absolutely. You just wanted to, I'm sorry, I didn't read it before, but yes, you can connect me, or you can reach out to me at marcy.hall@uhhospitals.org, and I can help you connect with a psychiatrist. There are psychiatrists in our area who do kind of have more knowledge in the use of marijuana for medical purposes. And I'm guessing they do the less than 10% thing, as you were describing.
Well, so the problem is there is no real regulation on that. And
Right.
so you don't know necessarily what they're recommending.
Right. And one other question, when they do buy from dispensaries, do they label the amount of THC per product, and how reliable is the labeling system?
They do, and it depends on the state. I'm almost certain that every state does. I can't imagine that there are states that don't, but I don't know that. I know that West Virginia does, and I'm pretty confident that Ohio does as well. So you can see that. But unfortunately, the promise of tight regulation in any of these states has not lived up to what was sold. And so you do see high variability, many gaps occur, and not only what is labeled in the product is that true, but then also the number of pesticides and heavy metals and everything that are in the product. And so just because it might say it's regulated, actually it's not well regulated.
That's a really good point. Well, this has been fabulous, Dr. Berry. Thank you so much for joining us this morning. This has been really a wonderful talk.
Dr. Berry, I wanted to be sure I thanked you. This was a great talk. It even surpassed my expectations. And we're certainly going to be looking for the presentation slides. Just thank you so much. It's been a pleasure getting to know you. And your talk was fantastic.
Yeah,
And it's
my pleasure. Yeah, anytime. I would love to come back in person at some point too.
We would love that. That would be fabulous. And
Yeah.
thank you, Ray. Thank you, Margie.
Thanks for
Paul.
everyone who stuck
Thanks
around
so
and listened.
much. Have a great weekend, everyone. Thanks.
You
Bye-bye.
too. Bye-bye.
See you
Bye,
next
everyone.
week.